Good afternoon, everyone. My name is Bill Tizensky. I am the program chair for the Joseph Priestley Society of the Science History Institute, and I'd like to welcome you to our February meeting. Our speaker today is Dr. Sheri Schully. She is the Deputy Chief Medical and Scientific Officer of the All of Us Research Program. This is a precision medicine program run by NIH. And in the interest of full disclosure, I'm proud to say that I'm actually a registrant participant, almost a lab rat for the All of Us program. You can read Dr. Schully's biography on the website, and I'm sure you have, and look forward to participating. For questions and answers, please enter your questions into the chat function, and I'll be monitoring them and asking them at the end of Dr. Schully's talk. So please do that. And also please keep your cameras off and be muted during the presentation. So with that, I will turn over the floor, and whenever you're ready to go.
Thank you so much, Bill. And we're more than delighted to have you as a participant in our study and welcome others to join. Happy to talk about that during the question and answer session. So thank you for having me here today. I'm really excited to talk about the All of Us research program and specifically about precision medicine and a little bit of the history about how the All of Us research program came to be. So my talk today will sort of go around what is precision medicine, sort of talking through how we got to be the All of Us research program, our current progress and what the program looks like, as well as some of our innovative measures, including return of information to participants, and then some conclusions. So I'm going to start off today's talk with a modern case study. So this is an actual event that happened. So let's just take from the left all the way over. So this is 1 year. A 57-year-old woman admitted to the ER with chest pain, and she had a heart attack. And so she received a stent and got put on clopidogrel. Over the next 12 months, she had about 9 stents put in and was basically in and out of the hospital for the whole 12 months. And so, it just leads us to ask the question, could precision medicine have helped change some of these outcomes and kept her out of the hospital a little bit longer? And I'll come back to this case study in just a few minutes. What is precision medicine? So it's an emerging approach for disease treatment and prevention that takes into account individual variability in lifestyle, socioeconomics, environment, and biology. It's a radical shift in how each of us can use and receive the best care possible based on our unique makeup and our environment. So just a little schematic that we put together here. So just imagine that you have a population on the left, and the way that medicine currently treats a population is one size fits all. But we know that we are not one size fits all, and that we are all made up of different environmental, lifestyle, and environmental genomic factors. So precision medicine is really taking those environmental, lifestyle, genomic factors and taking into account the population and being able to sort of parse out people into which intervention is best for them. This is just one example. You can also think of this as being preventive strategies or things like that, but it's really targeting to that person's unique makeup. Now, precision medicine is not a new idea. Back in the Greek times, they said it was more important to know what sort of person has a disease than know what kind of a disease a person has. So it's better to know about the person rather than the disease. And in the 1800s, a good physician treats the disease, a great physician treats the patient who has the disease. And so this is something that medicine has been striving for a long time. So let's go back to that example of the woman who had a heart attack. So we know she was given clopidogrel in January and still ended up in the hospital over and over again with stents and issues surrounding that heart attack that she had. But in December, she actually got genetic tested finally, and found that she had a genetic mutation in CYP2C19, which made her less likely to be able to metabolize clopidogrel and actually use it as a blood thinner. At that time, she was started on a new drug, which metabolizes a little bit quicker and doesn't rely on CYP219. And so her outcomes ended up being better moving on. But that took 12 months. And we really want to be able to shorten that time so that we're making sure that we're getting the right treatments to the right people at the right time. That being said, you know, to date, genomic studies and precision medicine studies in general have been very focused on people of European descent. So when we think about the US population, it's really hard for us to think about how we might do precision medicine for the more diverse, rich environment that we have here in the United States. And so it's one of the reasons why the All of Us research program was founded. So at the White House Precision Medicine Summit back in 2016, President Obama brought together a lot of thinkers in the field, and he says that he hopes that precision medicine becomes the foundation of the architecture whereby 10 years from now, we can look back and say that we've really revolutionized medicine. He formed a group who wrote what we call the Precision Medicine Initiative Cohort working group report that set the outline for the All of Us research study. It said that there should be 1 million or more people included in the study. These people should be longitudinal and recontactable. It should include, at minimum, electronic health records, biospecimens, and baseline exams. There should be a focus on engagement, participant engagement in particular, and there should be 2 different methods of enrollment: direct volunteers and healthcare provider organizations that can bring folks on board and into the cohort. So that leads us to All of Us. The study changed its name in about 2017 and started enrolling in 2018, and has really been innovative in how they're approaching both participant engagement, return of results, and the scientific agenda that the program is taking on. So the All of Us research program is a very innovative research effort. We focused on diversity at the scale of 1 million or more people. Very, very importantly, we focus on our participants as partners and not just research subjects. So we're really trying to change that dynamic of how we interact with our participants. We have a longitudinal design with the ability to recontact participants, letting us be a good platform for ancillary studies and things in the future. We have multiple data types, including electronic health records, surveys, baseline physical measurements, biospecimens, and then I'll talk a little bit about our genomics efforts. Can I ask you to mute if you're not muted? I'm getting a little bit of echo back. Thank you. This is a national open resource for all, so we're also changing the way that researchers interact with our platform. We hope to make all of our data broadly accessible to researchers with open source software and tools that they can use right on our platform. But all of this with the security and privacy safeguards for our participant data really in place and making sure that that data is safe. Our mission is to accelerate health research and medical breakthroughs to enable individualized prevention, treatment, and care for all of us. And we do this in 3 ways. The first is nurturing partnerships that last for decades with at least 1 million participants who reflect the broad diversity of the United States. We hope to deliver one of the largest, richest biomedical data sets that is broadly available and secure. But just because we build this platform and build this resource doesn't mean that people will necessarily come. So we need to catalyze an ecosystem with communities like this one and of researchers and funders who make All of Us an indispensable part of health research. So we really want to make All of Us really a cornerstone program within the biomedical enterprise so that it really becomes an indispensable part of what people do when they think about health research. We want to make sure we understand the whole person. And so we want to make sure we're looking at environmental factors. And here's some examples. We want to look at biological and clinical factors. We want to look at behavioral factors, including lifestyle. But also we want to look at social factors, including education level, stress, discrimination, things like that, that actually impact a person's life and where they are. Our current protocol includes EHR surveys, physical measurements, biospecimens, and wearables and digital apps. And I'll go into each one of these in a little bit more detail. So first is our consent and electronic health record authorization. It's important to note that currently in the All of Us research program, participants must be 18 years or older. So we're only enrolling adults. However, in the next year, we hope to start to pilot pediatric enrollment and really launch that in the next 2 years. We have a dynamic online video consent, and that consent process includes authorizations to share the EHR data with researchers. Right now, our initial data types from our electronic health records include demographics, visits, diagnoses, procedures, medications, labs, and vital signs. But in the near future, we hope to expand the data types to actually bring in some clinical notes, imaging, mental health reports, laboratory results, and things like that. So we get some more dynamic data that gets a little bit richer and actually gets to maybe what a patient had within that electronic health record that maybe we don't get from those initial more simple data types. I've also mentioned surveys. So we launched several surveys. We're currently doing about 1 a year, but we hope to get up to a clip of about 2 a year. Currently, we have a basic survey, an overall health survey, lifestyle, healthcare access and utilization, personal and family health medical history, and we just launched a social determinants of health survey, which I'm glad to say our participants have been asking for quite a while, and it will be revolutionary in how we sort of treat disease from more of a social standing and not just from a clinical or medical standing. We also take physical measurements when we have our initial assessment with our participants. We take blood pressure, heart rate, height, weight, body mass index, hip circumference, and waist circumference. We actually return the, if you see here, the diagram on the right is actually a form that the participant gets back with everything listed and sort of some helpful tips of where they should be with these measures. At that initial baseline exam, we also take biospecimens, and typically we take blood and urine from participants, but we'll also take saliva if blood is not available in order to do genetic analyses, which I'll tell you a little bit more about in just a few minutes. I mentioned that we also authorize people to link their wearable fitness devices, including Fitbit and Apple Health Kit. These are the two that we currently have on board, but we hope to have some additional integrations in the future with other apps and wearable technologies. So I'm just going to talk a little bit about where we are so far with the All of Us research program. We've made tremendous progress since opening our doors in May of 2018. And also want to talk a little bit about data access so that you can see how you can go about getting access to the data. So I first want to familiarize you with our Research Hub website. So it's researchallofus.org. You can go there. It's the first stop shop sort of to get broad cohort measures. We have some nice data snapshots, which I'll give you some examples of in a few minutes. We have an interactive tool that's completely public that you can search and look at all of our different data types and sort of what the magnitude is there. We have a survey explorer where the source information for all of our surveys is, so you can actually see which questions were asked, how we asked them, and where the survey question came from, because we always try to use validated instruments. And then finally is our restricted area, which is our researcher Workbench, which is a restricted cloud-based platform where you can actually do work and hypothesis-driven research. So here are some of those selected data snapshots that I want to show you. As of Monday, we had about 460,000 participants enrolled in the study. 318,000 of them had completed the initial steps of the program, meaning that they completed the first 3 surveys, provided biospecimens, and had physical measurements taken. 274,000 of our participants have electronic health records that we have been able to link to. And you can see that that's, a little short of the 318,000. So we want to make sure that we really meet that gap, and that's something we're working towards in the next year. And we have about 339,000 that have biospecimens within our large biobank at the Mayo Clinic. If you look here on the right, you can sort of see how we were going up at a rate of about 5,000 a week, which was really fast. And then our lovely cohort, COVID-19 hit just like it did everyone else in March of 2020, and we really had to halt enrollment. So since then, we've really tried to be innovative in how we continue to recruit folks into the study, as well as how do we go about getting biospecimens so we can continue our genomics pipeline, and it really doesn't halt the study as a whole. We have a commitment to participant diversity, so we want to make sure that we have representation from across the United States. And here on the left, you can see a heat map of where most of our participants come from. Currently, there's a little bit of a lighter pattern in the middle of the United States, and we want to make sure that we start to close that gap a little bit more so we can get some folks in from the Midwest and things like that. But we do have participants from all 50 states, which is amazing. Our race and ethnicity breakdown is here on the right. You can see that we have a huge representation of non-Europeans within the cohort, which is great, especially for genomics and precision medicine study, because as I said, those to date have not been very diverse and have really focused on people of European ancestry. And then you can see the age distribution here in the bottom right. I will note that about 80% of all of us participants are what we call underrepresented in biomedical research, meaning that they not only, we count several categories as underrepresented in biomedical research. One is race and ethnicity, but we also count disability, socioeconomic status, education, age, trying to think of the various things, but there are several categories that sort of count towards that underrepresented in biomedical research category. But I will note that 50% of our participants are of race and ethnic diversity as well. So we have a really high commitment to diversity. I had mentioned already the All of Us data browser. Here on the right is a snapshot of that. We actually launched that in 2019. It's almost 2 years old, which I can't believe because I was there when it launched. It provides summary statistics from the program's growing database, and it allows everyone to come in and see what we have. So, if you can see the various different tiles here, it has all of our different EHR domains, our survey questions, and our physical measurements, as well as our wearables. You can click on any of these tiles and find out more information about them, or you can do a search through the keyword search, and I'll talk a little bit more about that in a sec. The most important thing is it's open to everybody. This is public, there's no login, you can go to it as many times as you want. It's really great for sort of getting summary statistics on, what the cohort has for a talk and things like that. It allows our participants to go on and sort of understand what's making up our cohort, but importantly, it allows researchers to understand the characteristics of our population and sort of explore a little bit more of our data before actually going through the steps of applying to the researcher workbench. So it allows for a little bit more thinking and exploratory stuff before you actually commit to being part of the researcher workbench. So I've already mentioned that you can click on any of the tabs and get more information, or you can do a keyword search across all of the different domains. So for example, if I were to do a search for cancer, I would get the EHR domains that mention cancer, as well as any of the survey questions that mention cancer, and I could dive in a little bit deeper there. So one example is pain. So I did a search for pain, which is one of our highest counts within our EHR at least. And you could see that it gives us counts based on what we see within our actual data. It gives us the counts for each of the SNOMED codes, as many as the concept codes, as well as includes graphs where you can click on it and look at any of the sort of demographics that, for example, in this example, people who have pain and, look at by race and ethnicity, et cetera. So you can really drill down on the data, which is great. I did mention our researcher workbench, which is a restricted area. Everything that I've talked about so far has been public, it's completely open. A year after that, we actually launched our first researcher workbench. which allowed for, on a cloud-based platform, you actually get a workspace and you get an account there, and we actually have computational credits that people can use. You currently have to know how to code in R and Python. So that's one sort of hurdle that we're trying to bring in more tools so that more people can use it. But you can go on and build a notebook and start exploring the data. One thing that I want to mention is here in the middle, and we're really trying to innovate how we're giving data access to people. And so in your typical cohort study, and the way that it's been done for years and years, is you want to apply to use a resource and you want to get data from that resource. You put in an application, ask for access to the data. You say exactly what the data is going to be used for. You state what your sample size needs to be, et cetera. The All of Us research program is a little bit different in that you get access to the data. You go through a research ethics training and get credentialed to be in the data. And then you can ask as many questions as you want. You don't have to reapply every single time you want to ask a different question. You do have to let us know what you're doing so we can keep track and make sure that we aren't stigmatizing research or anything like that. But it really allows for more free access of the data and a little bit more freedom as far as what people can explore within the data. I mentioned that we're also doing genomics on everyone. And so the All of Us Genome Centers begin genotyping and doing whole genome sequencing on everybody in August of 2020. And we do plan on doing both arrays as well as whole genome sequencing on all 1 million diverse people. So this is going to be quite the resource, especially for those who want to study genetics or genetics in conjunction with some of the more complex lifestyle and social factors. The current output is about 5,000 per week. It's still been going at that clip even with COVID-19. So it's coming fast and furious. The initial genomic data, including many tools on how to that'll help use that whole genome sequencing as well as arrays, is coming hopefully very, very soon. So stay tuned for that announcement. I'll make sure that Bill and Shannon get that out to the group so that you know when it's out. But we also have many tools available for like touch button, really turnkey for GWAS studies, building cohorts, looking at genome structure, et cetera. Here on the bottom are our genome centers, and there's more information on our research, all of us that are excited about genetics, but wanted to let you know that's coming soon. We're going to release 90,000 whole genomes and 120,000 arrays, hopefully by the end of this winter. One other way that we're really innovating things is we're not only making this information available to researchers, but we want to make sure that we're engaging with our participants in a really meaningful way. And one way that we're doing that is actually returning results to participants. We currently are returning genetic ancestry and traits, including bitter taste, earwax, cilantro preference, et cetera. So sort of more recreational or fun things, as well as ancestry at sort of the continent level, like where your makeup is from. We have a dynamic consent for folks to get their DNA results. So we go through a whole basically consenting process, which we call an informing loop, that informs people what they're about to get and ask them if they want to receive that. So really, we want to provide participants choice on what genetic results they want to receive. So if they only want the traits and don't want to see the ancestry, that's fine. They can do that. We have a dynamic portal in which they can do that. And it's really an iterative process where they can decide not to look at it, but then change their mind and come back in and look at it if they want to. As I was saying, we have these informing loops that allow participant choice on whether or not they want to receive their genetic results, and they can even change their mind. We have two choices for genetic ancestry and traits. And so, as I mentioned, they can see if they want the ancestry and say no to traits, or vice versa, or get both, or get none. And it's really up to the participant on what they want to receive. So far, this is data as of November, but so these numbers have grown a little bit, but not a ton. Over 94,000 of our participants were sent notifications saying that they had genetic ancestry or traits available to look at. Of those, 68% viewed either their ancestry or traits result. And 89% looked at the traits, and 98% of the people who said yes, they wanted to look at anything looked at their genetic ancestry results. So that's a bit interesting as far as just return of results and the uptake of those. We will be starting to think through health-related return of results. And so I've already mentioned sort of the engagement piece with the ancestry and traits, but moving into this year, we hope to actually report back on hereditary disease risk, as well as pharmacogenomics or medicine and how your DNA really reacts to medicine, sort of that same example of clopidogrel that I gave in the very beginning of the talk. Are there medications that you're on that you may not be metabolizing, et cetera? So with that, I want to just end by saying we have a very robust, diverse and longitudinal data set with over 330,000 participants, lots of physical measurements. We have lots of electronic health records, many surveys, as I mentioned, as well as many wearable health data with 90,000 genomes and 60,000 arrays coming very, very soon. So this is going to be a resource that just continues to grow over time. And I just wanted to give a little snapshot of the Dado ecosystem and how it's going to grow over time. So if you look here, this little cloud on the left, we have 7 surveys, some physical measurements and structured EHR data, as well as some wearables. But we're going to be adding in constantly. So we'll be adding in additional surveys. We'll be adding in additional digital health technology. We'll be doing bioassays from our stored samples that we have at Mayo. As I've already mentioned, we hope to bring in unstructured EHR data, including clinical notes, imaging, labs, et cetera. We really hope to really enhance the data a lot with data linkages. So that will include linkages to GIS and actual geocoded data, claims data, and more. We hope to do a reassessment. So we hope to get additional specimens and measurements on our participants. And we'll be exploring many omics, again, with our stored samples that we have at the Mayo Biobank. So we are assembling the largest, richest biomedical data set of its kind with plans for genomic data and comprehensive clinical information. We are successfully engaging participants as partners and engaging them around return of their own information. We have new data types continuing to be rolled out along with return of results from many of those. Ancillary studies of specific populations or disease states will be possible, and we hope to roll out an ancillary studies policy in this next year. And we hope to facilitate research across multiple disease states, and we could even serve as controls for disease-specific studies where controls are really lacking. So with that, I will tell you, we certainly, one person can't do this alone. We have a huge community and provider partner network. This is the snapshot of all the different logos of people that we've been involved with on the community and provider level. And then we have our whole consortium that every time I feel like I share the slide, the icons get smaller and smaller because we're always bringing new folks in. But really, this couldn't happen without a really integrative effort across the US and over 350 clinical centers and research centers who are actually making this happen. So with that, I'm happy to take some questions and discussion. I hope you got up and stretched during my 5-minute break. It was all designed, went just as planned. But I'm happy to take questions, and Bill will be moderating the chat.
Okay, well, there have been a number that have come in, including comments, and I'll start with the first one is I've heard the term stratified medicine, and how does that compare to precision medicine?
So stratified medicine can mean a number of different things. Precision medicine actually uses the tools of genomics and other clinical factors to actually pinpoint medication, whereas stratified may use bigger chunks of demographic information and things like that to stratify by who should get what preventative or treatment.
Okay, another question is AI involved in the analysis of the data?
So currently we are talking with a lot of folks about artificial intelligence and machine learning. I think it's going to play a big part in making sure that we have robust data moving forward, specifically from EHR records. And the way that we need to pull that clinical data, we can't have all the personal identifiers within that clinical data. So we're really going to be relying on artificial intelligence and machine learning to be able to scrub through those clinical notes to make sure that we're getting the gist of what was going on with that patient, but all the personal, private stuff is really not coming as part of the data. So you can't identify them.
Okay, another question is, what is the cost of the program and how is it funded?
It's a good question. Okay, so we were funded through the 21st Century Cures Act, and we're funded for the first 10 years. And the cost of the program is a lot. I don't want to give the exact number because I don't know, and I'm afraid I'm going to say the wrong thing, but I at least know the scientific side of things, and the grants that we give out from NIH fund the clinical centers and some of our genome centers and our genetic counseling center, et cetera. But moving in the future, there's no guarantee of funding past 10 years. So if we really want to make sure that we're a resource that goes on for decades and really is engaging participants for decades, we're going to have to come up with really innovative public-private partnerships with the other institutes across NIH on how to fund ancillary studies and continue to grow our data and engage with our participants.
Okay, two comments from one person saying that she participated in a personalized medicine study by the Coriell Institute 20 years ago. And were those data incorporated into all of us? And then also mentioned that when she got the results back, she shared them with her doctor, who wasn't terribly interested. And how do we get medical professionals on board?
Yeah, so the Coriell stuff is not part of all of us. It's actually, and in the very beginning, whenever that working group got together and talked about what is all of us going to look like, one of the considerations on the table was, do we just put a bunch of other cohorts together and make a cohort of cohorts? And they decided, no, we'll really do this perspective, and we want to do this, moving forward. That being said, I think there's been a lot of advancements in medicine, and maybe not so much in primary care, but especially some of the specialties. They are incorporating sort of genomic and omic technologies and what they're doing. When we do the health-related return results to people, if they have a hereditary disease risk that's higher than normal, not only will they get to talk to a genetic counselor when they get the results back, but we'll also offer them a clinical validation, so they can actually give a new sample and get a clinical validation so that they can bring an actual lab report to their provider and have something that can actually be part of their electronic health record and their health moving forward.
Okay, one thing this statement brings up is she mentioned that was a personalized medicine study. Maybe you can explain on the difference between personal medicine and precision medicine.
Yeah, I mean, there's been a lot of back and forth within the literature as well as with the scientific community on, is it personalized, is it precision, what is it? And at the time, the director of the National Cancer Institute, Harold Varmus, who is a New York physician, said, every doctor tries to do personalized medicine. So why are we calling it personalized? It should be about precision and using cutting edge tools to figure out what's really going on with a patient. So I think the doctor and him really got offended by the personalized piece, because they all try to make it personalized for their patients. And so precision much more describes the using cutting edge tools to figure out what's going on.
Mm-hmm. There's a long statement in there from an attendee describing some medical effects from some chemical exposures over the course of his life. And you probably should capture that and kind of respond offline.
Okay, yeah, great.
So I think it's probably hard to do.
Yeah, but environmental exposures are something that we are really passionate about capturing on our participants, especially given that we're looking at underrepresented groups that may not even know what they've been exposed to. So yeah, I'm certainly happy to follow up offline, but it's something that we're very passionate about looking at moving into the future.
All right, two things that are kind of related. One is of the researchers using the data, how is that split between industry and academia? And then what do you foresee as products coming out of, or therapies coming out of the use of the data?
Yeah, so both of those are interesting questions. I mentioned that our resource is more or less open. And so in order to do that, we're really having to balance participant privacy with being as open as possible. And so right now, our resource is only available to researchers in the US and not for-profit companies yet. Although within the next year, we hope to really roll out industry partnerships, because we see that as a big place where drug repurposing, drug development, et cetera, can happen using our data.
Okay. And here's one is, do you consider all of us to be an extension of the Human Genome Project in terms of a project that ended up paying far, far greater social benefits relative to its de facto dollar cost?
That is exactly what we hope to do. And Francis Collins has been a huge advocate of ours, has been an advisor, even though he retired from NIH, has still been on our advisory panel. And certainly that is the approach we're taking, is that this is more of a societal benefit long-term than just a one-off research project.
Okay. Can you describe the backgrounds of, I say this, the subject area interest? Is there a particular disease that researchers are focusing on, or is it pretty much across all of them? Or is it a broad spectrum of interest?
Yeah, so, right now we have our researcher workbench, and we're trying to make sure we're keeping track of, what types of studies are being done, which data types are being brought into analyses, so we know what's most useful, et cetera. I would say across the board, we have a disease agnostic approach, but most of the research has been focused on a disease. So people they bring in are cancer patients or people with diabetes or whatever. So most of the research has been disease focused, although one doesn't pop out very highly over the other, just keeping in mind that with the numbers we currently have, it's mostly chronic disease at this point, and we can't do a lot of rare disease stuff. I think we'll see a big shift once the genomic data gets released. And we'll be keeping tabs on that, because I think we're going to see a shift in how people use the data.
Okay. One person said that she joined the program maybe 3 years ago, sent in her genetic sample about a year ago and hasn't gotten results. And what kind of timing should she expect?
I am also in that same boat. So they get to hear from people at the actual program who haven't gotten their results back. So we are, as I mentioned, we started genome sequencing in 2020. The health-related return of results is going to be later, but right now the traits and ancestry is rolling. And we hope to get through all that in the next year or two. So hopefully soon you'll hear something. And then as people enroll more real time, they'll start to see stuff quicker and quicker, just because we're catching up with that backlog of genotyping that we hadn't done.
Yeah, collection is a lot faster than sequencing, right?
Yeah, yeah.
What are the biggest hurdles to overcome before precision medicine is the norm of treatment?
I mean, I think one of the big things that our program is really addressing, and hopefully will really help break down a lot of the barriers, is, what do we do in people who are not of European descent, which is most of the US. And so that is one of the biggest hurdles. I think also access to care, and the fact that, some people just don't go to the cutting edge regional medical centers because they live in a rural place and they don't live near the places that have these cutting edge care. So we're really trying to bridge those gaps of folks that don't have access, folks who have not been represented in the past, and change the way that precision medicine is sort of looked at as a whole.
It was interesting. Last month, our talk was on how instruments like spirometer and pulse oximeter can exacerbate racial disparities in treatment. And next month will be the use of GIS, global informatics, in COVID treatment. So you're a nice right.
That's great. Yeah.
And fits right into that series. So
Yeah,
Um,
that's really great.
Can you talk about how you use informatics, global informatics? You referred to it briefly in one of the slides, or is that just starting?
So GIS, we're starting to do some linkages. We've been talking a lot with our colleagues at the National Institute of Environment and Health Sciences in North Carolina. They have a ton of resources. We actually have been talking with NASA. They're going to be doing a lot of like trans-US air monitoring and air quality monitoring. So we're trying to be innovative in how we do things, but make sure that we are also thinking about the return to participants, which is difficult, right? So telling someone they have lead in their water isn't just a straightforward, thing. That becomes a public health issue. So we have to really balance that because we want to make sure that our participants know what we're doing and are getting some value back from it.
Okay. Can you talk about how you vet researchers?
So currently, we don't vet researchers, except for, as I mentioned, the sort of caveat that we have, unfortunately, right now, where we can only take US-based researchers and non-for-profit, but that will be expanding. But anyone is welcome to apply to use the data. And so the vetting piece is sort of knocked down a level, which is part of the great thing about our data access policy is once you have access to the data, once you've taken a research ethics training and sort of understand what the data is and say you're not going to do anything bad with the data and you're in our cloud environment, there's no vetting per se.
Okay, so it's mostly around the ethics training.
Yeah. Which is pretty straightforward. I mean, it's just making sure you understand the data and what's acceptable or not acceptable with use of our data.
Okay, and you've scrubbed it all, so there's no personal identifiers.
Yeah. Yep. Now, as we start to give, more restricted access where we maybe are getting to the participant level stuff, then we'll be vetting researchers much more carefully. Right now, we have privacy safeguards in place, including like date shifting and other things like that, that really prevent people from identifying folks.
Yeah, that's a big issue right now, of
Yep.
course, is privacy protection. Let's see. I think that's pretty much most of the questions they had. You gave such a wonderful lecture. Everybody either Googled in their 5-minute break and got the answers, or you explained things perfectly clearly. So I appreciate that. Just a reminder to everyone that this presentation will be up on the Science History Institute website.
And I'm not sure if my email address was on my slides, and I apologize for that. I was just thinking through, I don't think I put it on there, but hopefully folks can find me on the All of Us research program page, and feel free to contact me after. I'm happy to talk about how we can collaborate and move forward. And I'm happy to also take ideas of folks, things that folks would like to see that we're not addressing quite yet.
Well, I'm happy to be a participant. I'm always excited when I get a survey to answer. And I know, especially through COVID, you did a lot of surveying to check people's mental health as it came through or how it was affected. And I'm sure that's all valuable data that will be used to as part of the public health effort.
And much of the COVID information is currently up on our researcher workbench as well. So
I have a question.
Yes.
Yes. My name is Bob Hirsch. I'm an anesthesiologist at the Cooper Medical School of Rowan University here in Camden, New Jersey. And it just dawned on me, we have classes full of medical students who are looking to do capstone projects in order to graduate. And what you describe sounds like a garden of earthly data delights for a medical student who's looking to get their feet wet in doing social determinants of health research in a diverse population. It's just like right up our alley. And I think if my dean could hear me talking to you, she'd get all excited.
I would be happy to come and talk to anyone about what we have. And we actually do hope to really open up training opportunities, and especially for diverse researchers, and really helping to build people's careers. That's what we're here for.
Is that like yes?
Yeah, all in.
Okay. Can I get your email?
Yeah, it's in the chat,
chat.
but you can also Google me. Hopefully you won't find anything bad, but.
Okay, sure.
And there's another comment here. It's wonderful to know such long-term impactful undertaking is happening. Can we factor in potential environmental impacts from climate change on health? Are you doing that?
It's great that this was brought up because especially with a lot of the major weather events that we've had recently that are affected by climate change, we've definitely seen people, be displaced and totally had their lives turned upside down. And so weather patterns, as well as climate change and weather events, is something that we hope to incorporate as part of that linkage piece that I showed you at the bottom. And part of the GIS piece will be about weather and what people are sort of experiencing.
Mm-hmm.
I mean, it'd be great to see if we're having a warming effect, if people are getting more tropical diseases and things like that, and really keep a tab on it.
All right. Since I'm sure most people took their 5 minutes to sign up as all of us research participants. As a participant, I just want to find out more. Can you describe the process for allowing you to get access to electronic medical records?
Oh yeah, so Bill and I actually talked about this during the intro talk where we were talking about my lecture. What we're trying to do is, there was definitely a difference between the number of participants we had and the number of access to electronic health records that we had in those two balls that I showed you. We're really trying to get this next year to close that gap on the EHR, to make sure we have EHR on as many participants as possible. And so we're trying a variety of methods, including having self-donation of EHR data, and seeing if folks want to donate their own EHR record, and showing them how to do it and making it easy and facilitating that. We're going to be launching some pilots this year. So hopefully very soon we'll be able to close that gap and be able to have more comprehensive electronic health records.
Okay, well, we are closing in on our 2 p.m. time. And one thing we try to do is start on time, and we try to finish on time. Although when we're live, I will say we don't always accomplish that because one question begets many. But and also we have lunch beforehand, so we don't always finish lunch on time. But anyhow, I'd like to thank you for your talk. Definitely very interesting and very informative. And I think just from looking at the comments and the questions that you received, certainly very engaging for our audience, and we appreciate that. And I look forward to everyone being with us next month when we have Dr. Estella Garrity of Esri, who will speak about vaccinating the world and the use of global informatics in helping to drive the COVID response. So thank you very much, and look forward to seeing you online next.
Thank you, everybody.